Hello, my name is Rachel Kadar, and today we're going to be doing one of our introduction lectures, performing a focused cardiovascular ultrasound or FoCUS exam. Today we'll talk about the normal exam. I have no financial disclosures. So today we'll talk about POCUS, FoCUS, bedside ultrasound, whatever you want to call it, and why we do it. We'll discuss the basic technique, and then we'll review the basic exam. When we talk about the basic exam, we'll look at the three windows. So the parasternal window, the apical window, and the subcostal window. And in each of these windows, we'll focus on the exams that we look for, the images we're acquiring when doing a POCUS exam. So in the parasternal, we'll talk about the parasternal long access view, the parasternal short access view. In the apical window, we'll talk about the apical four chamber. And then in the subcostal, we'll do the subcostal four chamber and the subcostal IVC or long access view. So point of care ultrasound, why do we do it? So point of care ultrasound is by definition, ultrasound performed and interpreted by the clinician at the bedside. And we're starting to sometimes even talk about the ultrasound stethoscope. So in the future, are people going to carry around little ultrasounds instead of stethoscopes to try and gather more information when they do their physical exam? Of course, this modality is user dependent. And so if we're going to use ultrasound, we're going to need to be able to train people on how to use it and how to acquire the images and interpret them. The benefits are that it's more compact, it's higher quality, and it's of course less expensive. This is a study from the New England Journal of Medicine in 2011, kind of talking about the different modalities of the different specialties and their ultrasound applications. You can see anesthesia and critical care are the two that I've put in a red box. And I would say that we use point of care ultrasound much more than what's even listed here. And so I think it will continue to expand in the future. So first, let's talk about the optimal positioning. You can either be on the patient's right-hand side using your right hand, which is how I was trained actually in emergency medicine, or you can be on the patient's left side using your left hand, which is how our cardiac ultrasonographers do it here at Northwestern. I would recommend the left-handed side of the patient using your left hand. As patients get bigger, beds get bigger, this idea of reaching all the way around over the patient, especially to get that apical view, as we'll talk about, can be really difficult. And so being there on that left-handed side is going to be a lot easier as there's more equipment in the room, kind of to have access to that patient. So for a lot of us, that might be a change in using that left hand, as we might be right-handed. But I recommend that you start learning and practicing with that left hand on the patient's left side. In either instance, we should have the machine on the same side as us as we're doing our exam. How are we going to hold the probe? So there's two basic ways to actually hold the ultrasound probe. There's the pencil hold and the screwdriver hold. I want to note that in both, you can see that those fingers are kind of at the base of the probe, kind of in that little groove. We're going to do the pencil hold and the parasternal views. And in the screwdriver hold, there's two. There's the overhand hold and the underhand hold. So we're going to use that overhand hold when we go to do that subcostal imaging, because you're almost putting that probe parallel or touching the patient. And so you'll need to have your hand out of the way there in order to get that image. And then that underhand hold with that apical view, because we're kind of starting on the left side of the patient, and that allows us to kind of appropriately put the probe where it needs to be. The most important part of all of this is that we always need to stabilize our hand on the patient's chest. So I never want to see a free floating ultrasound. I want to see that usually that whole hypothenar eminence of your hand is on the patient's chest. But if there's a reason where that's not the part that's going to touch the patient's chest, as long as you have some part of your hand stabilizing so that we don't slide around as we're doing our ultrasound. As I instruct you throughout our PACU rotation to obtain these images, we're going to use these terms. We're going to use rotate, tilt, rock, and slide. And so sliding is going to be just that moving across the chest into those different windows on the chest. Rotating is going to be, as you can see, kind of rotating the transducer like you would a clock, clockwise or counterclockwise. Tilting, which people often refer to as fanning, is going to be moving the ultrasound kind of in that direction of the transducer to kind of look back and forth. And then rocking is going to be kind of rocking that probe in the plane of the indicator. So kind of back and forth. And as we talk about rocking, rocking can kind of help bring whatever you're trying to examine from the right side of the screen to the left side of the screen, or ideally into the center of your screen to get a better look at it. So again, these are going to be the windows of the heart that we're looking at. So we've got that parasternal window. So you can see it's just next to the sternum. And we're going to have that short axis and long axis cuts through the heart. You got the apical view, which over here you can see is just by the nipple. And when we do that apical view, that window, we're kind of trying to look that beam up into the heart. And then the subcostal is going to be the subxiphoid. And you're going to have both the four-chamber and the IVC view. So that parasternal view of the heart, again, this is not how I would hold the probe. This picture is just done this way so that you can see which way the indicator is facing. This, again, you would do that pencil hold down at the base. It's going to be left lateral sternal border between the third and fifth intercostal spaces. And that indicator is going to be to the patient's right shoulder or around 11 o'clock. Of course, each patient's going to be different, so you might need to adjust. But that's about where you're going to start. Of course, you see this patient is on the left lateral positioning. That is going to be optimal, of course, for getting our exams, but oftentimes that's not feasible. And so I always make you practice with the patient flat on their back, or maybe a tiny bit of a tilt towards the left lateral, but you can always have them turn all the way over to the left lateral if you'd like to really optimize your image, and that's an option. What are we looking for? We are going to see that that interventricular septum should be horizontal. You're going to see the right ventricle, or that RVOT, right ventricular outflow tract, the aortic valve, the mitral valve, and the left ventricle kind of all in the same view. And we do want to note that we will cut off part of that apex to get that mitral valve and aortic valve kind of in the center. So these are all the pieces of the heart or anatomy of the heart that we're looking at in this view. Here's what that looks like on ultrasound. And what are we going to evaluate in the parasternal long axis view? Well, this is usually the first view I get, and I kind of get an overall sense of a lot of things about the heart. So we can look at right ventricular size and function. This is not the best view to look at right ventricular size, but it can kind of give me a window into the right ventricle, how it's working. The right ventricle should be about the same size as the ascending aorta or the aortic root, and it should be the same size as the left atrium. So if it's dilated, that can be something we might notice. Again, not the best view for the right ventricle size, but we can use it. We can look at the aortic valve. We can just look at it qualitatively. Is it opening? Is it calcified? We can look at left atrium size. So again, that should be similar in size to the aortic root and the right ventricle. So if it's enlarged, that can suggest we have some dysfunction, of course. The mitral valve, we can look at, is it opening? Does it come close to that aneroseptal wall and diastole, which we'll talk more in depth about on our global function lecture. We can look at left ventricular thickening, and we can look for pericardial effusions. So I can kind of already get a general sense as to what's going on with the heart. How do we optimize this view? So this is kind of a more FoCUS view, I like to say, of the parasternal long axis view, where you have to use a bit of your echo imagination. So to optimize this view, I often say we should start high and work our way down. We're going to often do some sliding. So if you look at the picture of kind of the heart in the chest, if we're seeing too much of that aortic root, we might be too high to those vessels, but kind of too close to the sternum or too high in the chest. So you're going to just slide down, or maybe even more lateral. Alternatively, if you're seeing too much of the apex of the heart, you're not seeing that mitral valve or aortic valve, you can see in this picture how you might want to slide up or medially to really get that parasternal long axis view. Oftentimes people will say, I see something moving, I see it contracting, but it's not the typical parasternal long axis view I would expect. Oftentimes the best thing to do is to change your tilt. You might be looking inadvertently at an RV inflow or RV outflow view, and if you change that tilt, you're going to be able to see that parasternal long axis view come into play. So now we're going to go on to talk about the parasternal short axis view. Now you can see that the only difference in this imaging is the indicator. So you're going to still be left lateral sternal border. usually between the third and fifth intercostal space. But again, start high and work your way down. And from there, you're just going to rotate 90 degrees clockwise from that parasternal long axis view to get that short axis view. That indicator is going to be approximately to the patient's left shoulder or 1 o'clock. And here's what we're going to ideally see in that view: a circular left ventricle right here and a crest-centric right ventricle. Now, our FoCUS view is going to be a mid-papillary view. So we want to see these two papillary muscles right here, and we want them to look even, to look the same, to know that our rotation is appropriate. We're going to see this right ventricle here kind of between 9 o'clock and noon. And if you don't see it, that's probably a good thing, because it probably means that it's not large and dilated. And of course, then we'll see that left ventricle. This is a great view, as we'll talk about when we get to our more advanced lectures talking about regional wall motion abnormalities. This is a great view to see all of our walls. So we have our 6 walls, remember: anterior, anterolateral, infralateral, inferior, infroseptal, and anteroseptal. Parasternal short axis view, what are we going to evaluate? This is my favorite view for left ventricle function. Everybody says, what view do you like for this? What view do you like for that? I think any pathology of the heart, you want to confirm it in multiple views. But if I had to pick one view to look for LV function, this would be it. You can look at symmetrical thickening of all the segments. I often say you can put your finger or your cursor right there in the middle of the ventricle and see if those walls are moving in and see if those walls are thickening. We can sometimes look a little bit at the right ventricle size. And we can also look at that interventricular septum. So right here, looking at that septum, we see that the left ventricle should be nearly a perfect circle. And if it's D-shaped, we can be concerned that that's pathologic, usually pathology of the right ventricle. And if that septum is flat and diastole, the typical thinking is that you have RV volume overload. And if it's flat and systole, you can have RV pressure overload. I like to note, though, that if you are very low on the chest in that parasternal short axis view, that septum might start to appear flattened just because you're very low on the chest and you're getting closer to that apical view. Or you're just getting closer to that view where the way you're cutting that image is making that septum look flat. So it doesn't always mean it's pathologic. It could be that you're just very low on the chest getting that short axis view. So to optimize that short axis view, if that left ventricle is too oval or too pear-shaped, you're probably too low. So remember, we said if you're coming down here and getting your parasternal view, if you're too low on the chest, you're really getting close to that apical view. Of course, you're more medial. But when you do that, this angle looking up at the heart is going to make that left ventricle look more like an oval shape, which will make that septum kind of appear to be flat, or it will look kind of more pear shaped. So in that instance, you want to slide up or maybe even more medial if you can. We can also tilt our probe in the short axis view, and that will allow us to see different pictures of the heart. We'll talk about that in our next lecture, which is the extended exam. But you can tilt through to look at the mitral valve and the aortic valve. And you can tilt also to look at the apex where you don't see the papillary muscles. And when you tilt, you're looking at different cuts kind of through that short axis view of the left ventricle and the heart. Moving on to the apical 4-chamber view. This is going to be in that 5th intercostal space, the mid-axillary line. And I often start at that first rib space below the nipple. Here, the indicator is going to be to the patient's left or 3 o'clock, or you can think of it as the indicator to the bed. And you can kind of see how this operator here is holding the probe in that underhand view. Of course, you would hold it closer to the base and stabilize your hand on the patient's chest. They're only not doing that in this picture so that you can see more closely how the probe is oriented. In order to get that appropriate apical 4-chamber view, the two things we're looking at is we want that septum to be vertical and in the center of the image, and we want that apex to be pointy, or we want that apex to appear triangular and not rounded. In that apical 4-chamber view, we're going to see the left ventricle, the right ventricle, the left atrium, the right atrium, and the mitral valve and tricuspid valves, all in this orientation. So here is an ultrasound picture of an apical four-chamber view. You see the left ventricle, left atrium, right atrium. We see that that interventricular septum is nice and vertical in the center of our screen, and we can visualize both the mitral valve and the tricuspid valve. This is the best view really to look at right ventricle size and function. The right ventricle should be 2/3 the size of the left ventricle. We can also evaluate left ventricle function in this view as well. We can look at the base of the apex, the base of the ventricle and see if it kind of moves up towards the apex, which we'll talk more about when we talk about our left ventricle function lecture. It's also known as MAPSE. We can look at the atria and their relative sizes. We can look at the mitral valve and the tricuspid valve, and we can look at those valves to see if they coact nicely, they come together. In optimizing this view, so remember we said that we want that apex to be kind of pointy and triangular and not rounded. And we want that septum to be up and down. So out of these two views, the one on the right is going to be less than ideal, and the one on the left is going to be more ideal. If you see that your picture is too rounded, we want to slide down or lateral. So if you look at this picture of how the heart is in the chest, if it's rounded, it's often because we're too high up or we're too medial, and we're kind of cutting the heart by not having our beam go all the way through the apex of the heart. If the right ventricle dominates, meaning that right ventricle is on the top of the screen, I like to think of it that we're closer to that peristernal view. And so we need to fix that. We want to slide lateral to try and really get that view. I do start my search for my apical here at the nipple, below the nipple, but sometimes I'm going all the way lateral up into the armpit here, or more medial in order to get that apical four-chamber view. It has a lot more variation, I find, than some of the other views. If you start to see a 5-chamber, which again we'll talk more about in the extended exam lecture, and you want a 4-chamber, you're going to tilt the tail up so that that beam goes more posterior into the chest. And if you don't see that left atrium, you can think about it as your ultrasound beams going too posterior into the chest, and you need to tilt the tail down in order to bring that left atrium into view. Now we'll move on to the subcostal 4-chamber view. Again, remember we said we're going to do an overhand grip here, the screwdriver hold with the overhand grip. And you can see again, they're kind of not holding the probe as close to the base as you usually would to let you see that indicator and see where it is on the patient's chest. The probe is going to be placed 1 to 2 centimeters below the xiphoid process. And contrary to what you might kind of intuitively think, we're going to actually go slightly right of the midline. And that's because we really want to go through that liver. The liver is a good acoustic window to look at the heart. So we want to go through that liver to get a picture of the heart. The indicator is going to be to the patient's left side, or 3 o'clock. And again, that probe is going to be almost parallel with the patient. So that's why we need that overhand hold so that that probe can get pressed down to be almost parallel to the patient. And we're going to use that liver again, we said, as a window to get to the heart to make the heart look nice and clear. What are we going to see? I call this view kind of the apical 4-chamber turned on its side. So we're going to see a lot of the same structures: right ventricle, left ventricle, right atrium, left atrium, interventricular septum, our tricuspid and mitral valves, and our inner atrial septum. What are we going to be evaluating in this view? I really like this for right ventricular systolic function. And so in the event that I can't get an apical 4-chamber, which is often the case because an apical 4-chamber in a patient that's intubated, that's lying flat on their back, that's difficult to turn in their left lateral, can be difficult in many patients, kind of depending on their anatomy. But if I can't get an apical 4-chamber, I often can get a good subcostal 4-chamber. And I can at least look at that right ventricular free wall, and I can see, is it coming in? Is it contracting? And I can look at RV function the same way I would as LV function. Does the chamber size get smaller? do those walls move in? This view, of course, can often underestimate right ventricular size, so it's not always the best view for size, but if that right ventricle is enlarged, you often will be able to see it in this view. This is the best view for pericardial effusion because that fluid will be right here between the right ventricle and the liver. And so you can better estimate the size of that pericardial effusion, and you can very easily see, does that pericardial effusion have concern for tamponade? Do we have indentation of that right ventricular free wall during diastole? Is that fluid preventing the right ventricle from filling? This is also the best view for status during a cardiac arrest, or the recommended view. During that pulse check, you can come in and quickly get an image of the heart, hit record on your machine. Don't try and evaluate and do image acquisition at the same time, and then step away and look at your image as they resume compressions. You can look for easily reversible causes such as large pericardial effusion. In addition, you can look for PEA versus pseudo PEA to see if maybe there's just a pulse that can't be palpated. Optimizing this view, of course, we want to use that liver as the acoustic window. So that's why we're almost moving more to the patient's right to get that beam to go through the liver up to the heart. While moving left may get the heart closer if there's not much liver on that side, it will probably make my image not as clear and crisp as moving to the right and further away. If the patient's able to participate, you can have them bend their legs or relax their rectus abdominis muscle to get this picture. Of course, if you have the patient as a slight incline and you're doing the rest of your cardiac exam that way, laying the patient flat is going to usually help with that subcostal view so that you can push underneath that subxiphoid process. And then don't forget to increase that depth to be able to see the heart. Next, we're going to go on to the IVC view. So again, you're still going to be in that subcostal location or window. You're going to be 1 to 2 centimeters below the xiphoid process. And from that subcostal 4-chamber view, I often rock the probe and then rock the probe to put the right atrium in the center of my screen, and then rotate counterclockwise about 60 to 90 degrees to get that indicator towards the patient's head, or 12 o'clock. And you're going to ideally see that IVC near horizontal to the screen and entering that right atrium. So you'll see the IVC, the right atrium, you might see the right ventricle, the diaphragm, and then really that liver on both sides of the IVC, so above and below, and then that left hepatic vein dumping into the IVC. When we look at the IVC, we can look at its size and its movement with respiration. If it's large with minimal respiratory variation, that suggests greater right atrial pressures. We can have a whole nother lecture where we'll talk about the IVC and what it means. And if we're going to measure it, we want to measure about 2 to 3 centimeters before entering the right atrium, just caudal to the hepatic vein. So you can see here on this picture, the IVC dumping into the right atrium and the hepatic vein coming down into the IVC. Oftentimes people are asking me, how do you know if it's the IVC or the aorta? There's different things we can look at. Thick versus thin-walled and pulsatility. However, I find that that can be very difficult because oftentimes the IVC is laying right next to the aorta and it will look like it's pulsating just because the aorta is pulsating. So I often look at where it's going. So the IVC, you should see it right here, entering the right atrium. Also for the IVC, you'll see liver on both sides of it. The aorta, however, you'll see it kind of diving down rather than entering the right atrium. And while there's liver on this side, you won't see liver on this side if it's the aorta. The left hepatic vein is also important. On the IVC, you should see the left hepatic vein entering at about 12 o'clock, kind of near that right atrium. The abdominal aorta, you will not see the left hepatic vein entering it. I always say, when in doubt, look for both. So remember, the aorta is on the patient's left side and the IVC is on the patient's right. So you can just do a tilt of your probe to tilt back and forth between the aorta and the IVC. And when you identify both, you can know that what you're looking at is truly the IVC. So again, we talked about the windows of the heart, parasternal, apical, and subcostal. In the parasternal, we discussed the long axis and the short axis view. In the apical, we did the four-chamber. And then in the subcostal, we talked about the four-chamber view and the inferior vena cava. Thank you very much for your time. Feel free to email me with any questions.